to which committee, and they assigned it to a committee. And I know Representative Greenlick was talking about committees, and the committee process in Oregon is really a critical part of the way we legislate. Committees really, they do all the heavy lifting.
So they just read the title?
They just read the title, and they'll say, and declare an emergency. So they'll say like, relating to healthcare and declaring an emergency.
And that's reading?
That's the first reading.
I've always conceived of it as being very different than that.
Well, I think that's probably how it was originally.
I see.
But the House and the Senate, they each adopt their own rules. And if you want to know anything about how the legislature functions, go online and look at their rules, because their rules are really what govern their processes. In fact, their rules would trump any state statutes over process. So I'm sure it's through rules that they've said over the years they don't have to read the whole thing, that they can just read the title. So then it goes to a committee, and first the committee chair will decide whether or not this bill has a life at all. And if it does, whether or not it's going to be scheduled for a public hearing or a work session. And the difference is a public hearing is just for the purpose of taking testimony. They can't take any action on a bill at a public hearing. They can only take action on a bill at a work session. And sometimes you'll see the agenda and it'll say public hearing and possible work session. So that means they might take action, but you don't know. So if you're following a bill and you're watching these committee agendas, which get posted online, the really critical thing to watch for is any bill that's coming up for a work session. And then there are time frames in which these committee agendas have to be posted. So for the first public hearing on any bill has to be 72 hours. After that, 48 hours for any committee meeting. But then, when the adjournment of the session is declared imminent by the presiding officers, then all that goes by the wayside. They have a public hearing, it only requires 24-hour notice. If it's a work session, 1 hour notice. So towards the end of session, things really get crazy. 1 hour notice before a bill's coming up for a work session. So the lobbyists just live there at that point. In fact, there is a group that set up a whole kitchen outside. Let's see. Okay, so it goes through the committee process, and when it gets down to the point where they're going to have a work session, the committee administrator, who's the staff person for the individual committee, will request a revenue impact statement from the legislative revenue officer, a fiscal impact statement from the legislative fiscal officer, this is on your flow chart, and draft amendments from the legislative council. So the fiscal, so here's the legislative fiscal office, legislative revenue office. They're two of the statutory committees, and they have very high-level skilled people who work for them. So when the bill is getting ready for a work session, the committee administrator will ask for a fiscal impact statement, which was a statement that says how much it's going to cost the state in order to implement this bill. And a revenue impact statement, obviously, is if it has any taxes in it, how much revenue it's going to generate and how it's going to impact revenue. And then, of course, we do any of the draft amendments. A bill can't come out of, generally under the rules for the last 18 sessions, they won't pass a bill out of committee unless they have those statements. So sometimes if the fiscal impact statement isn't done, the hearing will get set over. But anyone can ask for amendments, so any member or committee. So the amendment process is kind of interesting because you may see, let's see here. legislator amendment request form. Anyone can ask for an amendment, but they're confidential. So, and when we have the amendments, we number them numerically. So the first amendment is always 1, 2, 3, 4, 5, through 100. And so, but sometimes a member doesn't want to disclose that they have the amendment. So you'll have one member who requests 3 amendments, and there'll be 1, 3, and 5. So there's always this mystery, oh, who has another amendment out there? And everyone's trying to figure out who's got stuff up their sleeve. But, so you come down to the hearing.
Lori, this one says gotten stuff.
Yeah.
So
Yeah.
they really do say that, gotten stuff?
Well, the gotten stuff, yeah, let's see.
So basically that says, make everything else go away and just.
Here's an example of a gotten stuff amendment, and that's to Senate Bill 204, which should be in here.
Yeah, we have that copy.
The third one. So you'll see it says delete lines 4 through 10 and insert. So that's taking out all of the substance of the other one and replacing it with this. So we lovingly call those gotten stuff amendments. Sometimes we just have stuff amendments.
So that has the potential through the amendment process of completely changing the intention of the bill.
Exactly, but it still has to be within the relating clause.
Within the relating clause, you bet.
So this was still within healthcare, but it's completely changing the bill. Let's see. So they have the work session. They get their amendments, their fiscal impact statement. If they pass the bill out, then it goes back to the desk, or back to our office, and we draft the final, the bill with the amendments in it. Here's back to the measure history. So this particular bill had its public hearing and work session, and then passed out of committee on April 27th. And what I want to point out about this is the other thing that makes sessions so insane is the presiding officers will set deadlines for when everything has to come out of committee. So you'll note in this case, the work session was held on April 20th. You'll see the deadline for them to get the thing out was April 21st. So, like the day before the deadline, sometimes the committees will be meeting into the evening or on the weekends to try to get stuff out. Okay, so then, I would just another point I wanted to make about amendments. So like I said, the committee may have 10 amendments they're considering, or some of them they're considering. They may say, well, we want to do amendment 1, 3, and 5. We're going to adopt those. So they'll adopt those, and then they come back to our office, and we have to combine all of those amendments into one amendment. So if you go online and you look at the bills, they'll say, you'll just have one House amendments to Senate Bill 204. Even though that may be comprised of several different amendments, they're all combined into one. So you won't see all the different -1, 3, and 5 that we did. You'll just see a combined amendment. I think that's confusing to people sometimes. So like this is an example of a committee amendment request where she said the committee adopted these 2 amendments, so I combined them into one. And then those amendments, along with the House committee report, and the original bill, go back to the desk. This is an example of a House Committee report. The committee administrator does a staff measure summary, which says what the bill does. These are all available online. And then the desk sends it all back to us for engrossing. Engrossing just means we incorporate all of the amendments into the bill. And you'll see A engrossed, B engrossed, C engrossed, whatever. Every time a committee adopts amendments, then the bill gets engrossed again. So sometimes if a bill is jumping around committees or goes to the floor and then it has to go back to a committee, you'll get, up into the higher letters of engrossing. But that's what the engrossing means. Okay, so once it gets through the committee, then it goes back to the floor of the first chamber, and they have a second reading. The second reading is again just reading the title. And then usually the next day they have the third reading, and the third reading is when they have all the floor debates. They have really technical rules about how long you can talk and everything. Those are all archived on the web too, at least the audio. And so they have the floor debate. If it passes, then the whole thing starts over again in the second chamber. And this is a bill that's passing through committee without any problems.
So say that again. So let's say this is from the Senate. You've gone through this, and people have gone through this entire process.
And it passes the Senate.
And
then it goes back to the presiding officer of the House.
And then it goes to the House.
He or she assigns it to a committee.
And the whole thing starts over again?
Yeah.
Okay.
And the committee chair again has the power to say, I'm not going to let this bill go any further, and not even give it a hearing.
Or to gut and stuff.
Or to gut and stuff.
Okay.
And so if they make any changes to the bill, then the bill has to go back to the first chamber to concur in the amendments and repass the bill with the amendments. Or if they don't agree, then a conference committee is appointed. And the conference committee tries to work out the differences and come up with yet another bill, which then has to go back for first, second, third readings, depending on which chamber it's going to. So.
It's a miracle anything happens.
Yeah, it is a miracle, yeah. So then, I wanted to show this to you. So you'll see on this bill, May 27th, we're getting kind of close to the end of session because they wanted sine die on June 1st. Sine die means without a debate, and that's the final adjournment. So we're May 31st, it's finally coming out of committee, but you'll see the work session was held on May 27th. May 23rd had been the deadline for scheduling a work session, and June 1st had been the deadline for getting it out of committee. So the day before the policy committees all shut down, this bill finally came out of committee. So then, once it passes both chambers, the governor can either sign it or not sign it. If the governor signs it, it becomes law then. If the governor doesn't sign it, it just will become law without his signature. The governor has during session 5 days to sign a bill after it's passed, or it just becomes law without his signature. And once the session ends, he has 30 days, excluding weekends and holidays, to sign the bill. So, for example, for the 2012 session, he has until April 16th to sign the bills, or they become law without his signature. Also, he can veto a bill, obviously. but he has to give 5-day notice that he intends to veto. And then that can be brought back up at the next session of the legislature and override the veto with a 2/3 vote. So then the governor signs it or doesn't sign it. Then it goes to the Secretary of State's office. Secretary of State assigns a session law number. So you'll often see a citation to Oregon laws, section blah, 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 chapter blah, 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 Oregon laws 2011. That's the session law number. And then it comes to us, and we assign the statute number, and we put the code together and get ready for the next session. So there you have it.
That's, so this is an uncontentious bill, and if a bill is very controversial, it looks like there's almost no limit to the number of places where someone can try to impose their will upon the bill. Is that?
Right, and I also gave you the enrolled version of Senate Bill 204, just so that you can see what actually happened to it as it went through this process. So now we're still relating to healthcare, but we've created new provisions because we're amending statutes. We've added an emergency clause. We've added several more pages of stuff that came in during the committee process before the bill finally was enacted. But it should be separate.
We don't have it on the side.
Is that not going to pass out?
Yes, Lori, that's an amazing process, but, so with all of the healthcare reform legislation that's undoubtedly going to be going through the legislature in the next couple of years, how many bills will be introduced, on behalf of that? I mean, is it going to be just a huge increase in your workload? Or?
Well, I think, I started with Pledge Council in 2006, and we've reformed healthcare every year since. We just keep reforming it. But I think what we've done so far, for example, in House Bill 3150 in 2011 with the sort of permutations in the 2012, we've been changing Oregon law to conform to the federal. So I don't think there's that much more change that will come. Obviously, if the Supreme Court strikes down the healthcare law, then that will have some impacts in Oregon. But I think pretty much we're there. We've amended all the insurance statutes to comply with the Patient Protection Act, all the stuff that's currently in effect, and then projecting out to the changes that are coming in 2014. We have the health insurance exchange, which complies with all the federal requirements. In fact, Oregon was one of the states that got pre-approval for their exchange to go forward. I really don't think there's going to be a lot more, but of course I say that every year, and then there's another huge bill. Yes?
Is there a review process or a committee that looks at obsolete statutes and maybe laws that are no longer applicable and clear them at some point? Or do they just keep writing and writing and writing?
We have an internal process. We call it our pink sheeting process. If you see a law you think's obsolete or there's something wrong with it, we write up a pink sheet, and then whenever we're drafting our database, if we pull up that statute, it'll say there's a pink sheet. We go look at the pink sheet and it'll say this is obsolete. Occasionally, we'll just, we have every session we do a bill that's just sort of a cleanup bill, and nothing in it will have any substantive effect. But in that, we will repeal obsolete statutes, and that's just something legislative council does. So we don't have a committee, but within our office, we're always attentive to that and trying to get rid of things that are obsolete, update language.
Lori, the ACA has talked about accountable care organizations. Oregon has something a little different. And can you describe what you see the difference between those two being? Or are they essentially the same with different names?
The accountable care organizations under the ACA only apply to Medicare recipients.
Okay.
And in Medicare, there's a requirement that people have a choice of provider.
I see.
And so, as I see, the main difference between the CCOs and the ACOs is the regulations that have come down for the Medicare ACOs. What they do is they say, well, they figure out who your primary provider is, Medicare recipient A, and they'll say, okay, so your primary provider is Dr. Smith, and Dr. Smith is going to be grouped together with, Doctors Jones and Perkins, and they're going to be an ACO. So it's kind of, and the CCO is different because you have sort of a captive Oregon health plan, and they'll get enrolled just more like an HMO.
Right.
And they'll be within that CCO, they have to get all their services. Whereas with the ACO, you can get, as a Medicare recipient, you still go wherever you want. So it's not truly managed care.
I see. Good, thank you.
But it's just, the hope is that the providers will all get together, and by coordinating the care they give to these people, there'll be savings. And then they have the shared savings program that you get the money back that you save from coordinating the care.
Right.
But we'll see.
Yeah. Okay, yeah.
Yeah, I've actually read the Affordable Care Act, so if anybody has any questions about it.
Is it 850 pages?
Something like that.
Uh-huh. Okay.
It was over 2,000 in the original version.
Good Lord. Lori, thank you. Are there any other questions? And Lori obviously is an expert in this field, and it's not just how the Oregon legislature creates bills, but it's also broader aspects of the ACA and healthcare in the United States that Lori would be able to help us with the various questions that you may have.
I also want to note, I gave you an example of a fiscal impact statement, and that one's just separate too, because it's 3 pages, but if you want to see what a fiscal impact statement looks like, got a copy. Yes?
I wondered if, I know you had mentioned one way in which Oregon's process differs from the federal system. I wonder if there's others of note.
Well, see, most of the changes in the federal law that went into effect early on are Medicare changes. So, one thing that Oregon is doing is we used to have, we didn't have dual eligibles. In other words, people who qualify for both Medicare and Medicaid in the Oregon health plan. Instead, we would just pay their premiums, and then we would pay for any services that weren't covered by Medicare. And so one of the things they're doing with these CCOs is they're trying to get federal permission then to serve dual eligibles in the CCOs. So that's a little different. But all the insurance changes that were in the ACA, those are all pretty much mandatory, and we enacted those over the last 2 sessions. And then all the Medicaid expansions, those go into effect in 2014. We're actually working on that bill now to make those changes. But nothing else is really standing out as something different. States have 1 million options under the ACA, and we're not really taking up many of them. But one was to do the exchange ourselves.
And if the Supreme Court, and can you explain again what you expect the Supreme Court will rule?
I know nothing.
Sure.
But, but I listened to all the arguments, and my bet is that they will strike down the individual mandate and the guaranteed issue.
Okay.
Because there was a lot of discussion about how if you don't have the individual mandate, then the guaranteed issue is where you can't deny someone on pre-existing condition. You have to let anybody in. So they
Yeah.
both really kind of have to go together. Otherwise, people will wait till they're sick in order to get insurance, and then premiums will go through the roof for everyone. So, one of the issues was severability, and what other parts could be severed without turning down the whole act. So I think that's what I'm guessing. But I mean, they could overturn the whole thing. I mean, there were definitely some justices who were leaning that way.
I have a question, Bill. This might probably a basic question, but if they're all co-equal levels of government, legislative, judiciary, and all this so forth, how can the Supreme Court have the influence to say yes or no and get rid of the whole thing? If they are, sounds to me like the judiciary has the power to overthrow anything. I mean, it happened with, this is kind of a broader question, but it happened with Gore and Bush, and now it's going to come to this. What if the president still wanted to push this and the Supreme Court says no? What other measures can be done that, no matter what the Supreme Court, if it's treated like an equal, can still say, this is still what I want?
The Supreme Court, the U.S. Constitution, everyone's bound by the U.S. Constitution. So the only way they can overturn the law is by saying it's unconstitutional. If they say it's unconstitutional, there's no further appeal, it's unconstitutional. So then Congress would have to reenact whatever pieces of it that they want to reenact. If they pull out the individual mandate and guaranteed issue or any other pieces, then Congress is going to have to figure out whether or not what's left is going to work and how to patch it back together. The question of co-equal, the legal question before the Supreme Court is whether or not the federal government has the authority under the Commerce Clause to require individuals to buy insurance. But it's not an issue of whether states could. So, for example, any state could pass a law with an individual mandate, as Massachusetts did. But the question is whether or not the federal government is overreaching, because the federal government is a government of enumerated powers. In other words, the Constitution says this is what the federal government can do, and anything else is left to states and individuals. And so the question is, does the individual mandate fit within those enumerated powers that the federal government has? Does that answer your question?
It does.
So, the history of the United States, of course, is a reaction to the rule of the king. So the United States divided power among the states, and actually the power was with the states more than the federal government until last 150 years probably, but and then created the Bill of Rights, so that says each individual has these rights. So sometimes it looks odd to have the Supreme Court weigh in and say you can't do that, but that's our heritage. Now our heritage has a downside in that in other countries they say yes, we are Denmark, and as a Dane I have the obligation to my fellow Danes to participate in health insurance for all Danes, and I will pay in to make sure that all Danes have health insurance. Here we have, no, I have my rights, and I don't choose to have my tax dollars go to pay for other people's health care. That's my right. We have a completely different heritage, a different culture, a different, a lot of it is the history of how the United States came about that got us to the situation where we are much less likely than most other industrialized countries to take upon ourselves as individuals the responsibility for the whole. This is how I view it. And so a place like Canada, they say, well, I'm a Canadian and I have responsibility for even though they have a province system that's kind of like our states, they have a sense of responsibility for all Canadians, not only for healthcare, but also for paying for education, that we don't. I digress, but that's, I think our situation is unusual because of our history.
I have a question. So is it the individual mandate, is that the only portion of the law that's being reviewed right now by the Supreme Court?
No.
No.
All of the Medicaid expansions were also challenged as overreaching by the feds, and that was kind of an interesting argument because the Medicaid program is a joint federal state, so the states operated under regulations established by the Fed. The Fed will pay, in Oregon it's a 60-40 split. So like Mitch said, every 40 cents we pay, we get 60 cents back. And then it's higher for other programs. So it's a joint federal state. So you can choose whether or not you want to be in the Medicaid program. Any state can. But once you decide you're going to participate, then you have to abide by the federal laws. So the Affordable Care Act, then it expanded Medicaid to everyone within the incomes below 133% of the federal poverty line beginning in 2014. And so Florida, I think, challenged that on the basis that it's an offer that a state can't refuse because for the first several years, it's a 100% match. In other words, the feds are going to pay for all of it, all of the expansion. And then after that, it goes down to a 90% match. And so states that don't want to do it, they feel like they're being coerced because it's an offer they can't refuse. And so they're arguing that that's overreaching. I don't think the Supreme Court's going to buy that, but you never know.
So the question is it a coercion or is it not a coercion?
Yeah, right. The other thing and then of course the proponents or the opponents of the law are also arguing that the individual mandate is so integral to the whole bill that if you strike it down, everything else falls apart, and so they should overturn the whole law.
So can they make that decision that they can't?
They could.
I mean, so they
It
can
would
decide
be-
that even though the rest of it's constitutional, that because this one piece is so integral, it means the whole thing is unconstitutional?
They
Well,
could.
they wouldn't decide that, but, well, I suppose they could.
Yeah, they would
That's
say it's
what
not
I'm saying.
severable
They-
because they're all so
If it is so
intrinsically
integral.
related.
So they could say the whole law is out.
Yeah. Well, I think someone recently said that would be an unprecedented overreach. I think.
Yeah, who was that? Yes. On the other hand, if they just did away with the individual mandate, then it's difficult to conceive how it can be an adequate insurance plan.
So so if they do get rid of the individual mandate only, how does, what happens, technically what happens to the law at that point? How does it, where does it go for someone to fix it or?
Well,
does it go
Congress
back
has,
to
they
Congress, or is it done?
would have to, they wouldn't be able to enact another one. They'd have to figure out how to deal with the problem, but all the rest of the bill would go into effect, so.
Oh, okay.
And a lot of people say that, I've read people say that they don't think the individual mandate is that important because through the health insurance exchange and the expansion of Medicaid, you're going to have so many more people covered at a much lower cost, and mainly because of the exchanges, that people will get insurance because it won't be so prohibitively expensive. And because, in fact, I saw an article that said that actually the number of people that would be affected by the individual mandate would be very, very small. Because so many people would either be accepted because they couldn't afford coverage. There's a number of exceptions to the tax penalty, or they'd be covered by the Medicaid expansion. So the individual mandate actually, in practice, they say it's really only going to affect very few people.
So what happens to since the guarantee issue is so closely related to the individual mandate, if just the mandate is struck down, and the rest of the law goes into effect, that means the guaranteed issue also goes into effect.
Correct.
Unless another law is introduced to get rid of it. Would that be
Right,
correct?
that's correct, yeah. And so that's, all the economists are just saying that premiums will skyrocket under that. Now, already, if you're under 16, you can't be denied based on a pre-existing condition. But the rollout to the adult population begins in 2014. Yes?
There are a number of people that have employer-sponsored insurances, but they probably fall under the federal poverty guidelines. Is there an allowance in the Constitution for them to to refuse the employer insurance and instead qualify for the Medicaid, which is much cheaper? They don't have to pay anything, they don't have to pay any co-pays. Would they be, my question is, would they be allowed to do that? Would they be allowed to decline the employer-sponsored insurance and instead go for the Medicaid?
Yes.
And another question in relation to that would be, those people that are on Medicaid and Medicare are not allowed to pay anything to hospitals or providers. So for those services that may not be covered, or those services that that are not covered, what is the expectation for them? Because they're not allowed to pay anything in terms of, they're allowed to pay, but the providers are not allowed to collect any money from them. So what is the provision in that case if they need a service so badly?
Oh boy, you have a whole bunch of questions in there.
I'm sorry.
So yes, the final regulations just came out within the last month on the Medicaid expansion, and you can be in Medicaid. You don't have to take employer-sponsored insurance. The thing about not billing, it's true for a Medicaid recipient, the provider can't bill the difference. That's not necessarily true for Medicare. A provider can declare that they're going to bill the difference, but most of the vast majority of them opt not to. And it's weird things under the Medicare law, which I'm not really that familiar with. But and the non-billing part, at least in Medicaid, only applies, well, I guess it applies to Medicare too, to the services that are covered. So if it's a service that's not covered under the plan, then they can bill you for it, but they have to tell you ahead of time that you're going to be billed for it because it's not covered. Now, the Affordable Care Act requires the feds to establish a package of essential benefits, and that would apply to both Medicaid programs, benchmark programs, and to any of the insurance programs offered through the exchange would have to offer essential benefits. And there was a lot of anticipation about what that was going to be. And the initial guidance from the feds was, well, we're going to let states choose to begin with. And they can choose between the plan that covers their state employees, the largest group coverage plan. There's like 3 different options. And each state can choose whichever one it wants to be its essential benefits. But at some point, there's going to be a package that's going to roll out. I mean, one of the things that was interesting about the Supreme Court debate was some of the justices were saying, well, you've got a 20-year-old kid, he's not going to need heart surgery, so why does he have to pay for that? Or labor and delivery is included. Why does he have to pay for that with his premium? I mean, it's the same thing that your instructor was saying, that you have, it's basically we're creating this giant risk pool. You may or may not need any of the services. But I think the hope when they passed the ACA was that the essential benefits would actually be the essential benefits and not just some package that was put together based on what's affordable. So.
Well, that same argument could apply those to, like, say, property taxes. My property taxes go pay for schools. I don't have a child. Why do I gotta pay for a school?
Yeah.
Same kind of argument.
Same argument.
But nobody's contested that. I mean, I'm sure they have, but they still gotta pay property taxes.
But the schools are under local control as opposed to the federal law. The feds saying that you have to.
Well,
pay
I'm
property
paying
tax.
for, I'm paying for Medicare and I don't receive benefits. What do I care if I gotta pay for somebody older than
If
me?
we made it a tax for all this, but, to pay for the healthcare act, we could do that, but to force people to pay under the individual mandate, we may not be able to do that as a federal government. But tax, if they'd done it through tax, he said that would have been
Well,
constitutional.
I mean, and that's another issue that was in the Supreme Court case, is whether or not it's a tax, because the individual mandate, all it really is, it says if you don't have insurance and you don't meet any exceptions, that you have to pay a tax penalty. So obviously, if you don't pay taxes, it's not gonna affect you. And one of the big arguments before the court was whether or not it was indeed a tax, because if it's a tax, there's another federal statute that says you can't challenge it until it's been imposed. But-
Conceptually, I think Medicare is a prepaid health plan, so.
Just like Social Security.
And also on the
Yeah.
property tax,
Mhm.
you don't have to,
Not Medicaid.
right? So you probably don't pay property tax.
Yeah, but it's, you can say that's contingent. If you want to own property, the tax is contingent
Right,
on
it's
it.
not a requirement as a citizen of the States.
And the argument that's made for the health care mandate is everyone eventually needs health care. And so, you're gonna pay for it now, you're gonna pay for it later. This is just sort of prepaying for your health care now.
A quick question, Representative Greenlick kind of took pride in Oregonians doing their own thing and not being told what to do. But I noticed Oregon didn't join the 26 other states to oppose the Affordable Care Act. How did Oregon choose not to, or why did, what went into that?
Oregon actually filed a brief in support. The Oregon Attorney General's office filed a brief in support of the act. So, it was 26 states against, but there were hundreds of people in favor too.
I'm just for it.
I have a question that it may or may not be related, but how, for the ACO stuff with regards to, and this is particular to the state, and I think the OHA, how does, for the Medicare and Medicaid reimbursements they have now, where groups of physicians can join and become different tiers of primary care model medical homes that are related to these supplemental payments. If you reach tier 3, you get the most of the supplemental payment. It's regards to primary care as well as mental health. Does that fall under the ACO stuff?
You mean the CCOs?
Or the CCOs, yes.
The only Medicare recipients that will be affected by CCOs are the dual eligibles, so people who qualify for both Medicare and Medicaid. So Medicare, if you're, and that means you have low income basically, you're disabled. So the Medicare stuff, none of that's going to change. Everything with the accountable care organization changes on the federal level. Does that answer your question?
James?
I've got a question. So obviously, as someone who's a legal expert, could you explain the rationale behind saying, let's say, the individual mandate and the guaranteed issue are shot down? Could you explain why that's enough to take down the entire bill, especially considering that you can shoot those down just by the possibility those could just be shot down by themselves?
Well, the argument that was made was that the individual mandate and guaranteed issue are the heart of the bill. And if you rip out the heart, and that's the analogy he used, then you kill off the rest of it. None of the rest of it will work. And so that was the theory, that you can't sever those pieces without everything else collapsing.
Is it? I guess this is kind of maybe going to kind of enable this region, but is it really really the heart of the bill? Like, I mean, just in your opinion, or like, yeah, that's what that's kind of the impression that I got too.
You do think it is? Or
No, not at all. No, the thing is huge. it has, when I read it, I was just astounded by all the things that it does. It does millions of things, and
It was not gutted, it was only stuffed.
yeah, only stuffed, yeah, definitely stuffed.
There is a concern. How old are you?
26.
Why would you buy health insurance if you didn't need to, if you're not sick?
I could get sick.
You could get sick, that would be the reason, anticipating getting sick. If you weren't required to get health insurance, then many people your age would not buy health insurance. And then those premiums would not be available to pay for people who were sick. And that's really that's at the heart of insurance. And that's at the heart of the concern about that aspect of the bill.
Well, and the other piece is that under law, you can't be turned away from a hospital. So hospitals end up treating people, they don't get paid, those costs get passed on to other people who do pay the premium, so.
Another aspect of regulation we'll see a lot more of.
Well, that seems like it's like at sort of like at the heart of the whole idea of the individual mandate is that you are in the market, that you are someone that's going to probably at some point use health insurance, or if you ever need it, something's going to be there for you. If you're in an accident or something like that, you show up at the emergency room or a trauma or something like that, the money's going to be spent for you, and if you can't pay it, you can't pay it.
Right, that's the exact argument the government made, that we're all in the market. It's not like you can choose to buy property or whatever.
So unless you're willing to just, let people die and not allow people, not take people to emergency rooms, you really can't say that no one's covered by, some level of insurance.
Exactly.
Yeah, we do it oddly here. We do it through the back door for many people, rather than addressing the problem face on.
Which creates all kinds of problems on its own.
Yeah, no question.
You said earlier the mandate, some claim to be unconstitutional. What part in the Constitution says anything about a mandate being bad?
Well, the federal government has limited powers, and this is what your instructor was saying, that when it was set up, states were worried about the federal government having too much power. So they said the federal government can do these things. And states or individuals get to do everything else. The argument that's made is that, in favor of the bill, is that the federal government has power to regulate commerce, so interstate business and transactions, and that healthcare is an integral part of interstate commerce, and therefore it's within Congress's power to regulate that market. The people who are against the bill argue that it's beyond the federal government's powers under the Commerce Clause, that that we've never gone this far before, that the government is overreaching, and when the framers developed the Commerce Clause, they didn't have any idea that it was going to reach down and require an individual to take an affirmative act, as opposed to regulating things that people are currently doing.
So we all know that before the Civil War, the United States was called these United States, right? And then after the Civil War, people started calling it the United States, as if it were a single entity rather than a collection of individual entities. So that harkens back to that concept of individual states having many of the rights, and then only certain rights given to the feds. Yes.
So in some cases, don't federal laws trump state laws? And is that existed because whatever that law is, it hasn't been challenged?
No, if Congress passes a law that's within one of its enumerated powers, we have another clause called the Supremacy Clause that means that trumps any state law. So in other words, the state can't encroach on the power of the federal government if the federal government has passed laws in that area. If the federal government hasn't acted any laws in that area, then states can get into it. But
So it's
if they
beating until
have,
punch.
yeah.
Okay.
Well, we have cold cuts waiting for us outside the door. If there are no more questions, why don't we take half an hour and thank Lori. And Jill Verhagen, Deborah Woodcock could not make it, Barbara Bonise, Elizabeth Brentdahl, Williams Brentdahl, and Paul Liebergott.
Yep.
Sign in
I'm
here.
yeah,
Great.
okay.
So let's talk about a few housekeeping things, and then we'll talk about the survey that most of you did, and I know who didn't, and who that'll give some sense about who the class is and who you are and what you all want to get out of the class. So some housekeeping things. I think that you all know by now that the postings need to be done by Wednesday. So I mean, I'd never taken an online class. I'd never certainly taught an online class. The philosophy is that if you can engage the students in a conversation, that they can hear different points of view and learn, flesh out the ideas from the textbooks. And indeed, as we will see, this is a group, you are a group of folks who have have about as many, almost as many background areas as there are people in the class. So it's a very diverse group. And so then it's a very diverse set of points of view that were expressed at least the first week. So that said, coming back to the idea of the postings being done by Wednesday night, there really can't be a conversation if people are posting on Sunday. So if your first post is on Sunday, then you've not engaged in the conversation and the learning objective is not met. So please be sure to at least start your postings by Wednesday evening. Now, the other thing is that all the other postings, all 6 groups, postings should be available for you to peruse. So it might be worthwhile to look through there. At the present time, it appears that when there is a topic of conversation in group 1 and I respond to it, that groups 2 through 6 are not able to see my response. So if there are questions that come up that I need to weigh in on, then it's right now pretty divided up and partitioned. So that might be something, if there's something that the tenor of the conversation is, well, what about this, what about that? And if I weigh in, you might have to look at other postings to see my contribution for what that's worth. But there might be ways around that. It's a little clunky right now. However, please post by Wednesday. You've read, some of you have, I was very polite at the beginning, and by the time I got to group 6, I was less than polite with people who were posting on the second thread. So there's someone I need to apologize to. I'm not quite sure, but I was quite curt by the time I got to the last thing. It's like, no, we can't have 36 different threads going in this class. We need to have 1 thread per group so that everybody in the group sees in the 1 thread of discussion all of the points of view that are being posted by that group. So some of you have gotten a little feedback, please delete what you posted in the second thread and put it back up in the first thread, and that's just kind of how it works and how it will need to work. Otherwise, you'll be talking to yourself in your own thread. About the field book. You know, on the face of it, I mean, I think that probably, I mean, with, you know, apologies, I think that probably some finance classes are regarded as a little more boring than healthcare regulation and legislation. But it is kind of it can be kind of a dry topic. It always seemed like it to me, although I'm kind of waist deep in it in my real life. But the field book makes the topic more interesting, I think, because it gives the historical perspective. And the reality is that we really don't know why we are where we are without the historical perspective of how we got here. Now, so a lot of the field book is, you know, what Nixon did. You know, I mean, it goes back and talks about sort of the evolution of thought to our current state, and a lot of those are failed thoughts when it comes to healthcare. But I do want to say that, you know, although the field approach of putting a lot of pages into the history of how we got to where we are really does make the topic a lot more interesting. It's certainly not a requirement of the class that you know any of that. You know, I mean, it is important to know what healthcare regulation in particular is at the current time. And reading the field book is very helpful to get you to the place where you understand what the current state is. However, none of that is, I mean, I certainly don't expect anybody to really retain any of that information in terms of the nuts and bolts of what Truman did, or, you know. However, it is very helpful background information, and without which it's really sort of just rote memorization to understand the healthcare regulatory state that we find ourselves in now. So please feel free to look at field in that light until you get to the things that are currently in force, the Stark regulations, you know, HICWA, HIPAA, all the things that currently are so strongly influencing American medicine. And there are a couple of exceptions to that. As Mitch said, Oregon is a unique state when it comes to healthcare. Let's see, very early in my career, I knew a pediatrician, Dan Rappaport. And Dan was a really good guy, but Dan always looked like he had the weight of the world on his back. And indeed he did. Dan had joined a clinic at the coast that was in the middle of some litigation, and that litigation went all the way to the Supreme Court of the United States. And the litigation resulted in every member of that clinic having to pay a surgeon treble damages for an antitrust act. That case was the Patrick case, and you'll be reading about the Patrick case in our own Astoria clinic, Astoria, Oregon. And the Patrick case created, as a result of the Patrick case and then subsequent legislation introduced by our own Ron Wyden, there is a unique set of rules governing peer review for medical staff in the United States. So obviously the Oregon experiment with healthcare rationing, nobody said rationing today. I don't think anybody said rationing, but maybe rational, but the Oregon experiment really is healthcare rationing. The Patrick case and then Ron Wyden's introduction of HICWA, those are important things for you to get out of the class, if only so that you can have a unique sense of Oregon's role in healthcare. Let's see. So who's ever heard of the word preventate? Or prevention? Does anyone know those words? who's heard of the word preventative? Well, preventative comes from the root preventate, and another form of which is prevention, or other people call them prevent and prevention. So in the same way that preventate isn't a word, neither is preventative a word. Now, dictionaries, online dictionaries don't catch it, but I would like for you all to be erudite in your discussions of healthcare when you leave the class. And part of that erudition is the understanding that the word is preventive, not preventative. So, and I know that there are two members of the class, Shauna Hoffman, would you raise your hand, please? And Mariah Hayes. Raise your hand, thank you very much. These are two members of the class who know that the word is preventive. And they might be the only two, but so please, the word is preventive. And this, I know this is really picky of me. But, and then the second thing is is something else, which is you'll be required to submit 4 essays, and in the essays you will refer to sources of information, and the sources of information that I would like to see are authoritative sources of information. I just want to make the point that Wikipedia is not an authoritative source of information. Wikipedia is subject to change. As a matter of fact, I heard someone was talking about Willie Mays and Willie Mays' statistics, and a guy wrote a book about Willie Mays, and so he was, way big time expert on Willie Mays. And then he looked at the Wikipedia citation, and he said in the first 2 paragraphs, there were like 6 errors. I mean, just sort of glaring errors about, number of hits and blah, blah, and this and that. And so he got online, and of course, as you can, he changed the first 2 paragraphs of the Wikipedia article on Willie Mays. And then a few weeks later, he went back, and there were 8 errors. And then he kept changing it, and the number of errors kept expanding. So someone somewhere had different thoughts about what they wanted Willie Mays